Hi, Camille.
Hey there, Carolyn. How are you?
I'm doing well.
Thanks for
Um,
helping out with this.
Pardon me?
Thanks for helping out.
Oh, no problem. Um, I am going to go ahead and give you host, but everything is being taken care of as far as recording and sharing screens.
Excellent. Thank you.
Okay.
Are you going to make Cora a co-host when she joins?
Now that I've given you host, you can go ahead and do that.
I can do that. Okay. Okay.
Yeah.
Thank you. Hey, Cora.
Hi, Camille.
How are you?
Doing well, thanks. How are you?
I'm good. I'm going to make you a co-host so you can share slides if you have them.
Okay, I do. Thank you.
Yeah, and think of any questions that you'd like to ask the group. We usually have about 20 to 30 people joining us.
Okay. And what would you say they are mostly? focused and what do they do?
Well, everybody that joins, and in addition to those that join, are partly from there, they might be NIH program officers, but the people that are affiliated with Bridge to AI are
Hmm.
responsible for creating databases that are going to be used for machine learning and AI training. So one of the data
Ah,
generation
okay.
projects is creating a prospective database that involves people that are pre-diabetic or diabetic.
Okay.
And what they're doing is creating this database with underrepresented populations. Another one is collecting voice samples. And so learning how to detect disease based on voice
Uh-huh.
samples. Another one is using ICU records from 14 different hospitals to create a data set that can be used for, again, machine learning and AI. And the last one is using cells, and that's a UC San Diego led initiative. So all of
Super.
these different groups, they're clinicians, they're data scientists, there are ethics folks involved, there's lawyers. It's just a really interesting cross section of people, which is really important to have in this kind of field that's emerging. We have people who are interested in community partnerships. So I
Great.
was thinking that the work that you're doing is just very practical and applied, and trying to figure out how to get the UC patient records in good use. But many of the things that we talk about here at this discussion forum are focusing on governance and stewardship, ethical practices, things that you've learned along the way that you've had to kind of navigate and rethink. Because again, this is a learning, it's a learning community that's trying to share as much as we can with one another so that when we make mistakes, that we can elevate what we've learned from those mistakes. So it's it is an interesting group. We'll probably have
Super.
more people joining, but I'm going to look for my introduction for you,
Okay.
and then we can go ahead and get started, and folks can join in. Let me see where that went. Here we go. Give folks another minute to get started here. And thanks for doing this. Thanks for making time. I just think that the
Of
work you're doing
course.
with the Center for Data-Driven Insights is super relevant here.
Oh, no, it is my pleasure. And all of the things you just listed, the topics near and dear to my heart. So it's going to be a great discussion.
And Sam says she's eating lunch, which is what most of us should be doing at noon on the West Coast. Yeah, we have I don't know how many institutions are involved, but there's, you know, does anybody on the call know how many institutions are involved? I think it's got to be something like 30 at least from across the US. And we have groups that are developing standards, ethics, trying to figure out also how do we share data? How do we disseminate it? How do we sustain these data sets once the NIH
Hmm.
funding
Yes.
is stopping? A lot of these things, you get started really, really quick, and then all of a sudden the money starts to come to an end, and maybe you didn't prioritize sustainability. So all of those things I think are really important to us. So, well, it's 3 after, so I'm going to go ahead and get started.
Okay.
Welcome everyone to our Bridge to AI Ethics Discussion Forum. This is April 2026. This may be our last discussion forum as well because our funding does stop here at the end of April. But we keep everything that we've been doing at our ethics discussion forum on YouTube, and all of these are recorded. So I'd like to take a moment to welcome Cora Han to who will be speaking today. Her talk is on making health AI work, turning principles into real world impact. And Cora is the Chief Health Data Officer for UC, University of California Health, where she directs the Center for Data-Driven Insights and Innovation. which is a system-wide data platform that leverages health data to improve health care, to drive research, and to foster innovation. She also directs the UC-wide data governance initiatives, including the responsible development and application of AI in healthcare. And previously, Cora was a senior attorney with the Federal Trade Commission in their Division of Privacy and Identity Protection, where she played a leading role on health privacy and matters in enforcement and policy, something that I think is incredibly critical. And I'm often curious, and you may talk about this, Cora, did anyone ever fill your place when you left? Because I've heard that a lot of those jobs have remained empty. But let me turn it over to you, and we're recording, so so take it away.
All right. Thank you, Camille and group. I am delighted to be here. I'm gonna share my screen and hopefully pull up some slides. Let's see. All right. And then kick things off. So I actually came to California in 2019, about 8 months before the pandemic. So the direct answer, Camille, to your question is yes, my role was definitely filled. It was a while ago now, and it has been a wonderful time being part of the UC system. So I'm going to talk a little bit today about how to turn principles into real world impact, and take us through a number of different topics. And then I'm really looking forward to the discussion. So I'll start with a little bit of background about where I sit at UC, and talk a little bit about the center that I run, which I think Camille referred to in her introduction, and then walk through some of the principles for responsible AI, but really, because I know this group will be well familiar with those, turn to pain points and progress, like what we're really seeing across our academic health systems as we try to develop and deploy AI at scale in the healthcare delivery system. Then I'll talk a little bit about the quickly evolving regulatory and socio-technical environment, which I think are key elements of any successful deployment. And it's interesting and very true. It is often said that the regulatory environment not keeping up with the pace of technological change. That is not a new phenomenon, but particularly exacerbated, I think, in this time. And so while not moving evenly and not moving as quickly, there are still some interesting things going on there, kind of in all sorts of different directions. And then I'll talk a little bit about what we're thinking about looking ahead. Okay, so first let me start with University of California Health. So what are we? We are really one of the largest academic health systems in the nation, with 6 academic health centers, 21 health professional schools, a global health institute, and a number of services we really provide for UC employees and students. So I am part of the system-wide offices of University of California, and one of the divisions is University of California Health. A number of years ago, the academic health centers at University of California decided to aggregate all of their electronic health records into a single data lakehouse, which we call the UC Health Data Warehouse. And it is run by my team up at the system-wide level, and we are called the Center for Data-Driven Insights and Innovation. The largest purpose that we have at CDI2, as our short name is to really help UC Health become a data-driven learning healthcare system. And so we have these records as well as a few other data sources that we leverage for a number of system-wide priorities, largely around improving patient care and achieving certain efficiencies. Because we have the very rich data that we have from across the system, we are also able to leverage it for some other purposes quite efficiently. And those, for example, include research. We have a large secure research enclave that we make available to UC researchers for their projects. So this was something that was that really got kind of started our research side during COVID because we were able to make available a COVID research data set of de-identified data. Actually, formerly it was a HIPAA limited data set to UC researchers, and they were able to very quickly jump into it for all sorts of pandemic response projects. So what data do we have? We have data on more than 10 million patients that have been seen at a facility owned or operated by a UC Health academic health center for longitudinally for over the past 14 or so years. And it ends up being sort of billions of data points. So procedures, medications, diagnoses codes, labs, vital signs, as well as genomic data as well. So the data that you see in the box here is structured data, and that has been our primary focus. But we also do have clinical notes as well that we are starting to move into all of our initiatives. Okay, so we of course are doing a lot of AI projects at the center, but I wanted to give basically a very high level snapshot of just a few of the many, many, many AI use cases across all of UC Health. And I tried to pick some examples for this slide that capture kind of the diversity of use cases because AI really lots of initiatives across all of the aspects of the healthcare delivery system, from administrative to treatment to revenue cycle to all sorts of things in between. And so I picked kind of a smattering here and also tried to pick from across all of our 6 academic health centers. So here on, in the top corner is a research initiative out of UCSF and UCLA on the predictive modeling front. And we see a lot of this. This particular project was about, combing clinical records to be able to develop a model that improves the detection of rare diseases. And we see this across all of our locations on many, many different types of disease and other kinds of activity. So we also have predictive models that can help identify patients in need of care management. So care management, care flow, this is another very big area of activity. This particular one out of UC Davis also was focused on advancing health equity. So it was really on helping to predict what patients might need immediate care, help keep them from being hospitalized, and help give them the services they need to help deal with those problems before they end up in the emergency room. In the middle here are the ambient scribes, which I'm sure everyone on the call is well familiar with. This is a very, very well-received set of products that are high in use, I think, at UC and everywhere else. And they have really helped our clinician base with gaining some extra time, particularly pajama time, back from their interactions with patients, and have also helped, per some feedback that we've been getting, also helped with changing the nature of that interaction so that they are able to spend less time looking at their screen, more time interacting with their patients, and that is a win-win. So this has been a really, really popular AI use across UC and everywhere else. In the bottom right, an effort from UC San Diego, a research effort to use LLMs to actually improve quality reporting. So this is a project that I was very excited to see because our team helps with a lot of quality reporting. And this was really a project that showed that quality reporting would be also quite accurate using LLM tools. So this is an area that I will be very interested to see kind of how it develops. And then on the bottom other corner here, it's a project that our team was also involved in. And I raise it because it also is an example of how there can be efficiency in model sharing. So this was another predictive model. This is actually not a new use case. It was from a few years ago, but that helped to develop at-risk patients in the primary care population as it relates to emergency department visits. And it was a model that was developed at UCLA and then scaled system-wide in our environment, and then ultimately was able to be utilized by another UC Health location. So this is a type of AI project that our team does and probably will be doing more and more of. Okay, so these here are the principles for responsible AI. These are ones that, as I mentioned in my intro, these are terms that I think everyone on this call is well familiar with. They're fairly high levels, and I won't dwell on them. But this particular set came from NIST and NIST AI management framework, which is really one of the, I think, foundational governance documents. And the one that I always add, and that really has become more and more and more important, is the one about addressing workforce impacts. This is a topic that more and more is top of mind, and I think deserves a good deal of attention because certainly AI technologies are going to have a significant impact on the workforce. And it is important that there be, upskilling of the workforce as needed to be able to adjust to some of these things as they're happening. So, with appropriate sensitivity and thoughtfulness, and it's challenging when things are moving so quickly. So I did want to call that one out. But let me turn now to what are some of the pain points we're seeing in the healthcare delivery system, particularly as we think about trying to develop and deploy some of these technologies. So first, many competing vendors. We are really being flooded with point solutions, and where in prior times there might have been three possible vendors for any particular kind of use case, now there are 10. And just throwing that number out there. And the landscape is really quickly changing. So to give one example, ambient scribes, robust market for ambient scribes. And at UC, for example, there's not one single choice. There are a variety of choices across our academic health centers. And this group may have seen, but Epic is also rolling out their own ambient scribe. And when that happens, that could quite change the marketplace. And so from an enterprise standpoint, this can be a challenge. And one of the things that I am seeing that can be helpful to help the system remain nimble is to think about, rather than long multi-year enterprise agreements, doing shorter term agreements, recognizing that it is not clear who the front runner will be or who the most appropriate front runner for our particular workflows might be. Related to that is a lack of assessment resources. So monitoring, validation, all of these things require resources. There are never enough resources, and this is a challenge. To keep up with the flow takes a lot of time and effort from a multidisciplinary group of people. That kind of focus is important, but the lack of sufficient resources can often be a challenge. I'll talk about the regulatory and policy environment in a minute. And then the fourth bullet is the need to increase transparency. This is a constant, but with the fast evolving landscape can also be a challenge. Just keeping up with ensuring that those who are utilizing the tools and those who are being impacted by the tools, whether they are inside or outside the system, all have the information that they need about what tools are being utilized, how it may impact them, what they might be able to do about some of those impacts should they disagree. Demonstrating measurable ROI is a continual challenge. And that ROI can really be more than just financial, and often is. It often includes things like quality, safety, other kinds of operational gains. And so there needs to be effort put into sort of how we measure that so that we can remain kind of accountable. And utilization of these tools is also not free. So assessing when it makes sense and how it makes sense is always part of our calculations. And then finally, complex implementation workflows, which again I'll talk about a little bit later. So, okay, so we've talked about promise, we've talked about principles, I think we've talked about pain points. Now I'm going to spend a minute talking about privacy enhancing technologies, which I bet is not a new topic for this group. I'll say that that AI governance, a core part of it is data governance, which is another topic that is near and dear to my heart. But because AI really runs on data, strong data governance, I think, is a very, very important kind of base foundational level. On the very plus side, I'll say that there are a lot of existing processes and procedures and risk-based frameworks that already exist across all of our UC health locations, as they have been vetting all sorts of different technology solutions for many years, and so that has really been a plus. There's no need to recreate the wheel. There is already experts who are very, very adept at rigorously applying risk-based frameworks to new technologies, and so we've been able to kind of really, really build off of those, and that also helps a lot with workflows. So one area that I think I am personally hopeful about is the development and continued evolution of what I call privacy enhancing technologies, or PETs. These are technologies which help mitigate risk. Technologies that help mitigate risk, but that also allow sensitive data to be used and shared securely. And there are certainly challenges, and I'll get to those in a minute. But one of the things that these tools are really able to do is help promote and accelerate usage of tools, but do so without what really some of the very common data risks are, particularly in the privacy and security area. This is an area that I also think NIST has done a lot of good work on. They have a lot of good materials up on their website about this. And privacy enhancing technologies can range from encryption to trusted execution environments to synthetic data. There's a lot of talk about that recently, to adding noise to data sets to create differential privacy, to federated learning models, where for example, our team participates in models like this, where the analytics are done locally and only aggregate results are shared. So you're able to do the analytics without actually sharing any of the patient data. And you're able to actually then even update models, which then can be applied again in the same kind of federated approach. As I said, there are some challenges here. I would say most particularly there can be and often is, I would say, a data utility versus privacy trade-off. So, for example, the more noise you add to a data set to achieve more privacy, the less utility you may be able to get out of that data set. Our team and others at UC who are considering these types of technologies, these are definitely the things that we discuss and weigh. And in the healthcare context, there are many situations where we are, for example, not able to use privacy enhancing technologies because of the nuance of the data and what we're trying to do. Another challenge can be technical complexity, because deploying privacy enhancing technologies does require expertise in cryptography, sometimes machine learning, and it can require a significant amount of compute as well. But as I said, it is an area that I am excited to see developments in. I think the desire to utilize a lot of these AI tools may lead to further development. developments. And so I think it is a space worth watching. Okay, I'm going to switch gears now and mention a little bit about how I see what's going on in the regulatory environment. I'll talk about the federal side, and then I'll talk about the state side, and a little bit contrast the two. Because in my view, what I see from the federal side right now is really a deregulatory push. So I see, and here are just three data points here. But the White House over the summer and since then as well have put out a number of plans and executive statements and orders that really highlight their desire to accelerate innovation while removing onerous regulation. And that is a common theme of a lot of the White House's efforts, I would say, over the past year. And so in the White House AI Action Plan in July 2025, they sort of have set out a roadmap. And then in more recent pronouncements have actually also talked about activity they would like to take in vis-a-vis the states, which I'll talk about in a minute. But so this is a core part of their deregulatory push. Another data point is the HTI-5 proposed rule, which came out at the end of 2025, which among other things proposes to eliminate some of the earlier AI model card requirements and a number of the certification requirements for EHR systems. And then early in this year from FDA, new decision support software guidance, which indicated an easing of regulation for certain digital health products like wellness products. And so that is a little bit of what we're seeing from the federal side. Whereas on the state side, I would say we're seeing a lot of activity. So I've just mentioned two recently passed bills from California, but we're seeing state activity, I think, from all of the states, and California is a particularly active state. But the two I mentioned here are SB 53, which requires certain transparency reports and also whistleblower protections for frontier AI developers, so the developers of the big models. There was a lot of, I think, push-pull as this bill and its earlier predecessors was making its way through the process. But SB 53 is what finally made it through. And I'll note that SB 53 also contains a provision in there for a large scale computing resource called CalCompute, so a public computing cluster. And so it will be interesting to see sort of the contours of that as it starts to move forward. And then second, AB 3030, the Artificial Intelligence in Healthcare Services Bill, which is focused on requiring disclosures when generative AI is used in patient facing communications. There is a carve out here for when those communications have been reviewed by a provider, but otherwise it is an important transparency requirement when generative AI is used that there be a clear disclosure. Another interesting thing that is happening on the regulatory in the regulatory environment at both, I would say, the state and federal level is this idea of a regulatory sandbox, which could mean different things, but largely is a time limited, closely monitored place for some experimentation in autonomous models that might inform updates to a later regulatory regime, as I would like to say. So two examples here on this slide. The first, and this got a decent amount of press, comes out of Utah, an agreement between Utah and Doctronic to have a partnership for AI prescription medication renewals. So part of this is that it happens in a regulatory sandbox. And what it actually will lead to is basically a regulated pilot that allows an AI system to renew routine prescriptions for certain chronic conditions within a closely monitored oversight framework. So the idea is that there would be accountability and monitoring and evaluation, but also have there be the potential for there to be an autonomous prescription renewal for certain set prescriptions. So this is just kicking off, and we'll have to see how it goes. And the second of these is an FDA initiative called Tempo, which is a first of its kind digital health pilot to expand access to certain chronic disease technologies. But you're starting to see uh, this idea of a regulatory sandbox become, I think, more popular. And there are certainly, I think, risks involved. But on the other side, also perhaps a recognition that given the potential lagging of regulations to the technology, experimenting in kind of a safe, monitored way could enable a better evolution of those laws. So we'll see. So at UC Health, we have certainly done some system-wide advocacy as the different requests from the agencies have come down over their AI plans. This is one that we wrote to NIH in 2025. Really focused this one on funding research that supports real-world evaluation and implementation of AI, recognizing that for healthcare, the implementation and how that goes is incredibly important part of the story. Which is actually takes the thunder out of this slide here. So this is very commonly recognized now, and there is a lot written about it, but certainly validation is only the first step. It is important, but it is only the first step. Whether or not any particular AI tool will succeed in healthcare really depends on implementation into fairly complex workflows. And so that means that it can be hard, particularly at the beginning of things, to tell if the ROI is there. But the good news is that there is a lot of work being done on this, like at all over UC Health, but also the federal government has a lot of really strong initiatives here. And so this data and these results will definitely start to come in. I'll point out just one at the bottom of the slide. UCSF a year or two ago received a large gift to develop an AI monitoring platform, and I think we will see more and more monitoring platforms come into play, given the scale and complexity of all the different deployments that are actually happening. So, and then I think my final points are really here. So, also important from a socio-technical perspective is to think about what is really happening in the patient and consumer space right now. So I think a lot of the early talk when generative AI was really just kicking off was really about the importance of patient trust in the healthcare delivery system. Patients want to know how is AI being used in decisions that affect them, and what might they be able to do about it? It is exactly things like that that really have driven laws like AB 3030, and that remains a very, very important part of the equation. But patients are also consumers, and consumers are utilizers themselves of the numerous tools that are proliferating, including tools coming directly to them from the large LLM providers. And so consumer use, I believe, will also shape expectations for care. I think what we really saw at the end of 2025 and through 2026 have been a lot of direct to consumer efforts by ChatGPT, by Claude, by the large pharmaceutical companies. A lot of we are now, we are company consumer um, companies as opposed to sort of B2B companies, and it'll be really interesting to see how that develops. There have been in prior times, I think, a lot of efforts to bring patients directly their records, and those have never quite taken off in the way that some I think hoped, some expected, some feared that they would take off, depending on where you are in the ecosystem. One of the most interesting things I think about chatbots is that they are very democratizing. They take complicated descriptions and journal articles, and they make them very easy for anyone really to understand. And yes, there are definitely still issues with hallucinations, but nonetheless, the nature of that interaction, I think, has the potential to shift how consumers take in their healthcare. And already we see a little bit in the press about the percentage of chatbot questions that are people asking questions about their health, about how people are bringing in questions that they have, fairly detailed ones, from these tools into their provider interactions. And I think that has the potential to shape, I think, how they expect their care will be given. And I think it will be interesting and potentially exciting to see the healthcare system's response to that, and hopefully some of the patient parts that might come out of that. And then my final thought here is that design choices, of course, embed values. So one of the core questions, always important to keep in mind, and I'm sure this group has thought about, is whose values, are these? Whose values are the ones embedded in the tools? Dr. Isaac Kohani from Harvard, I think, has an interesting project going on called the Human Values Project, and he notes that the same tool asking the same question in the hands of healthcare providers might yield a different result than that tool in the hands of payers, and so I think it is a good question for a group such as this one to think about whose values we want to be embedded in the tools that we provide. And from a patient-centered standpoint, how do we really, really bring in the voice of the patients? So I think certainly innovation is important, but governing well, in my view, is essential. A few quick takeaways from the deployment standpoint. I think always important to start with a need that can be addressed. I think it's important to recognize that the tools can provide benefit, and I think I mentioned this, even when they don't save time, or even when they don't save money. That is not always the easiest argument to make. I will fully acknowledge that when it comes to funding. But I think one of the most promising things to come out of how ambient scribes have been rolled out is that it enables clinicians to be able to spend less time looking at their screens. It is certainly a multidisciplinary game, and that is easier to say than it is to do. It requires bridging and understanding and openness to talk across silos. Predictive and generative AI present different risks. There are unknowns about generative AI that I think make governance in many ways much more challenging. And then, of course, over and over again, understanding how AI tools are implemented in the workflow is critical to success. All right, so I have talked a lot. I am going to stop talking, and then looking forward to some discussion.
Thank you so much, Cora. That was wonderful. I'd like to invite those of you here to turn on your video if you don't mind and participate in our conversation. One of the things that I'm going to go ahead and ask this first question, because I think your second to the last slide really hit home with me about how important it is to do values sensitive design. There is a methodology called value sensitive design, and it involves iteratively engaging with people who might be called patients. They might be called clinicians. They could be called consumers. And how it is so important. And I know that it comes up often that's important, but I don't see it demonstrated very often. So I have two questions related to that. How is the UC doing this in your wheelhouse, specific to this and I don't like calling it a warehouse. It's more like a resource because it's such a valuable resource. It's almost like a national park. Um, how are patients engaged? And then also with all the things that are being learned from the UC researchers who have access to these data, how is that being shared back? Because I've been putting all of my papers through Claude and asking it to convert my research into something that's consumer friendly, and it does it in a nanosecond, and it's really good. But how are we conveying back to patients what we're learning and how we're improving? So those are two very patient consumer focused questions. And then my other question was what is your gateway for researchers in the system to touch the data? Like, what do you expect of their qualifications? And what do you ask of them before they have access?
Okay. So let me start. I guess I'll start with the last question. I'll work my way. I'll work my way forward. So, with respect to our secure research enclave, which we call our UC Data Discovery Platform, the biggest threshold requirements, I'll explain how we go through it though, is that it is a data science environment. So you need to have coding skills to be able to utilize that. And that is actually one of the most common barriers that we hear is that someone doesn't have the technical proficiency to be able to utilize our environment in the way that they would like. Now, if they are part of a research team, it often could be that they have a data scientist on their team who is able to help them with some of the work that they do in our environment. But that is certainly one requirement. We are absolutely, because we have heard this feedback loud and clear, working towards easier to use tools to enable easier access to the data, even by those who um, may not have coding technical capabilities. And so those include things like a patient self-serve patient cohort explorer tool and things like that. But you do need at this point to be able to go in and sort of code in our data science environment. You do need to have technical capabilities. So otherwise, often what we do is I would say the most common pathway to get in to utilize the system-wide data is that at any health location, working with your local, we call the research responsible parties, who are people who know our environment well and are at their locations, and they work with researchers at their locations. On their projects, and often those projects are run locally and then scaled in our environment. It's not the only way that things happen, but
Mhm.
that is a common pathway, so that there can be because our system-wide team is kind of small, so that there can be sufficient support at the location before they get to the system-wide data. It is a HIPAA limited data set that has been determined to be our research environment, non-human subjects research. So that means that you do not need IRB approval to enter the environment, but you do need to have worked with your local research responsible party, on the what it is that you are looking to do. So. So that is that question. I'll talk next about transparency to our patients and our community. So that is Camille is I mean all the questions are good. That is such a good question. We are focused on thinking through what might be the best way to do this. So, and this has come in several different ways. So, one of the things that I and my team led, let's say now 2 or 3 years ago, was a system-wide task force about health data governance. And some of the recommendations that came out of there really focused on how to do community engagement and how to bring the patient voice into decisions about how their data are used, and potentially how to bring them into committees and to rooms where those decisions are being made. There are certainly some recommendations of that report that we still need to move forward on. But for our team, I can say that one of the things we do is have patient and community engagement voices on our oversight board. And our oversight board, and what I mean by that is the board that CDI2 reports up to quarterly about the work that we are doing across all of our spheres, operational research, some of our industry collaboration work, and that uh, we did deliberately so that we would be able to bring in voices from the community to talk with us about the work that we are doing. So that is one effort that we have. Another one, though, that I think is important because when you mentioned how do we be transparent with patients about some of the results of what is happening in the research that may involve them. That is something that has come up actually in some of the work we did as we were coming up with those recommendations about community engagement, and there were very candid and important conversations that we had about what are the incentives to researchers to do that? And how do we enable more of that information to go back out? And how do we do that in a way that is that people can actually understand? And so we have some efforts underway, for example, at our team, to be able to offer some communication out through, for example, our websites about what it is that we do with patients' data, and how here are some of the research efforts that have gone on using, for example, our research environment. So those are kind of in the early stages, but that is kind of how we are looking at that. And then I think
I
your
think that's
first question.
really,
Oh, go ahead. Yeah.
I was just going to say that's really exciting because I think when people start to get accessible information about what is being learned, they get more curious and they get more interested, and it increases that trustworthiness and partnership basically between the public who might be a patient and those people who are accessing data to do really cool stuff. But that cycle of communication, I just think is really, really important.
I completely agree with you. And this was this was part of the conversation we had as part of our governance process was, um, was talking to, the research community who to some extent, may feel like, oh, now my project is done. And so, but some of that communication still
You
should
know,
continue.
it's
So,
so true because researchers are not incentivized. There's no money in their grants. The funders don't ask for this. And so there's no pathway for it to become part of a workflow or a norm without it being a requirement by the sponsor to do this and to be able to budget for it. But with the generative AI, it's a very quick way of putting something out there. And then the researcher only has to verify that it's not inaccurate. Like
right.
I had to read a computational science paper about a year ago, and I had no idea what it was telling me. And I needed to know what it was telling me. So I put it into, at that time, I think I used GPT. And I said, explain this to me like I'm a behavioral scientist. And it just did such a good job. But then I had to send it to the author and say, did it get it right?
Right.
Because I'm not a subject matter expert in that space. So it's such a useful tool for being able to convey things to people. And you mentioned that earlier. Sam, do you have questions?
I don't really. I've just been fascinated by the discussion. It's an excellent topic. I love everything AI. I'm a behavioral scientist. I'm a qualitative researcher, and I use a lot of the popular AI programs, ChatGPT, Claude, all of the time. And one of the things that I think has been implied, because I'm talking about more tools that are more researcher specific, um,
Ah,
is just this need to know your topic so completely that you know how to identify a hallucination. And
Yes.
that's what Camille is talking about as well, is you can easily get trapped in liking the way something looks and reads, but not realize whether or not it is accurate and not really even know why it isn't accurate.
Yes. I
And
agree completely.
I'm wondering, with regard to patients and involving patients in this process of being able to use AI to access information for themselves, what what are probably the bigger needs to get across to patients about what they need to know when they start using any type of program that allows them to kind of play around with their data?
I think you hit the nail on the head with a big one, which is that that AI needs to be checked. It often is trying to be supportive of you, the asker. So I
Mm-hmm.
think that has a potential warping effect on the answers that you get back. And that I think one of the trickiest things that I have also found in my own work is that is exactly as you said, it can be hard to really uh, tell if there is something slightly off in an answer.
Mm-hmm.
And so in areas where accuracy matters a lot, frankly, that concerns me, right? Right. I mean, I can tell in areas where I am a SME, but it means that in areas where I'm not a SME, it's still happening, I'm sure. And
Mm-hmm.
I just can't tell as much. So to Camille's point, when she said, so I asked the author, right, to check. In many ways, I think you just have to know when you need to do that and then do it. Because the biggest risk I see is that people won't really be able to tell. They won't ask, and then there'll be information that's just not correct, kind of floating
Right.
around. So I think those are great points.
Well, I can also appreciate that patients may use any kind of AI generative um, program to do something like, and I did it the other day. I was trying to look at for more information on red light therapy, and I got information back, but whether it's accurate information. So then I went back in with the prompt and said, I want accurate information so that I can do a better search on different products. And I find that unless I use and have learned real exacting kinds of prompts, my information that is returned could be all over the place.
Hmm. No, it's true. Sometimes I will, in certain situations, ask for citations so that I can check the
Yeah.
citations and see. But I think there was like someone who recently said, the AI that you're using now is the worst AI you will ever use. So I think
It's
there is a
right.
thought that and people should be, monitored for this, but there's this thought that like, the tools are going to get better and better, and better, and that will, become at some point less of a concern. But I think the other point about consumers is that I think regardless of the hallucinations, I think we really are going to start to see more and more usage by consumers. Whether or not they'll be like comfortable enough to upload all their medical records into ChatGPT,
Right.
I don't know the answer to that, but I think absolutely specific health questions are being asked all the time, and people are taking that, as they did with Google, but even more so into seeing into their providers. And so
Do you follow Hugo Campos?
I do.
Yeah, Hugo's done some really incredible
Yeah.
stuff with his medical records and using a chat bot as an agent to schedule for him and
Yes.
anyway, his Medium posts are really great. I
Yes.
wanted
In
to
fact,
just
oh no, go ahead.
No, I just wanted to ask you a little bit more about like when I was asking about who gets in to use the data.
Okay.
And I had two concerns that jumped out at me. One was that it's not considered human subjects data, which I get, that there are ways to make it so that it's not, but it's still human data. It's just
Absolutely.
not covered by regulation at that point, which doesn't mean that you don't need to do ethical work and responsible work. And so when the next piece where you said they have to know how to code, one of the things that I've thought about from a data scientist perspective versus a clinically trained person is, as a clinically trained person, you have to take clinical ethics. You are socialized as part of your education about ethical research and ethical clinical practices. So it's kind of it becomes part of your socialization.
Yes.
It's always something you're thinking about. Whereas in data science, there isn't a professional norm. There isn't a certification. There isn't a license that's associated with your profession. And so there is a real missingness in that training pathway that is problematic. And one way that one access point for one of the grand challenges, this is a data generation project, was if you're going to access, meaning that you could actually download the data, public access, and all you had to do was attest that you have received some form of training in research ethics. And there was one other thing, you had to sign a license. So you just are self-attesting that you won't, and the other thing was is that you won't do stigmatizing research and you won't do something that could cause harm.
Yes.
So what I would like to see, and if it's not in place right now, is something to recognize, some form of recognition that that is missing. And so what kind of responsible research practices could they be exposed to know that even though it's
Uh,
not regulated,
no.
it still has to be treated with respect, that you have to think about risk versus benefit, that you have to think about equity and justice. So I'm not really sure where that can fit, but I know it's something that popped in my head as you were describing.
No, I think that's hugely important, Camille. And I should be clear. I don't you'd asked about the process for getting in. It is non-human subjects research. That doesn't mean I consider it to be non-regulated in any way, shape, or form or form. It actually is we have a lot of aspects of that. I think the only people who are able to access it actually have gone through all of that training at their locations. So
Yeah.
we are not open to, you need to be a data scientist to utilize it, but we're not open to data scientists across UC, for example. They
Okay,
don't.
that's good to
The
hear.
access is yeah, access is very limited to. You need to have like a health center
Okay.
ID and have gone through all of that, all of that, as well as like had your project vetted and by others. And so
Oh, that's good to
also
hear.
you are not able to take out the data in and you sign a long attestation every time you get in, and you're not allowed to take it out. You're not allowed to combine it. You're not allowed to re-identify.
Mhm.
There's a whole
Good, good, good.
set
Good to
of
hear.
restrictions about
Let's
utilizing the data.
ease my
Yeah.
anxiety a little bit.
Yes, yes, yes. No, no. In fact, it is we often get pushed in the other direction. And we are beginning to work on opening up access to example for our health professional schools who are not located at a health campus.
Yeah.
But by and large, it is limited, and you're not allowed. Non-UC people are also not allowed into the environment. We get that question
Yeah.
a lot. So
Well, I really appreciate you joining us today. And again, we record these and it's going to be put up on our website for Bridge to AI. And also, I think it's on a YouTube channel that we maintain. I still have more questions for you, but we are out of time. I wanted to get into sustainability, but we only have 2 minutes, so I won't do that. But anyway, want to just thank you so much for joining us. I think this may be the last discussion forum. because we're not certain about our funding moving forward. So if we do continue, I'll keep you all posted. But for right now, we don't have anything scheduled for May. And so you might have just been our last wonderful speaker. So thank you.
Well, I'm honored. Thank you for having me. It was great seeing all of you. Uh, and I look forward to more to come in this area. There's always a lot happening. So
That would be
Yes, there
great.
is.
That would be
Thank you
great.
so much, Cora.
thank you.
Okay, take care.
Bye.
Bye-bye.